Okay, let's get started. It's now 12 p.m. So welcome to the first in a series of 4 lectures on epidemiology. I'm Dr. Jan Corrigal and I'm a public health specialist from South Africa. I've worked in a number of different countries as a public health specialist for governments, NGOs, and epidemiology is really the foundation of public health. So every single job that I've done has really rested on information gained from epidemiological studies, because it really helps us to identify who is affected by what diseases, who are the highest risk groups, and that, as you can imagine, informs health promotion, it informs health service planning, and obviously it also informs the development of treatments and cures applied to at-risk populations. So let's begin the lecture. Just to give you a brief overview of what we're going to be looking at. So I'll do a brief recap of the definition of epidemiology. We covered that in the natural history of diseases, and so we'll just revise that. We'll then have a look at some of the history of epidemiology. So how did this type of study and way of studying disease come about? We'll then have a look at what are the practical applications of epidemiology as they're used today. And some of those include measures of disease frequency and mortality, which is really the basis of epidemiology. And then we'll have a very brief look at some of the achievements of epidemiology and public health, so that you get a sense of really how powerful this tool is in achieving public health outcomes. Right, so let's begin with the recap. So what is epidemiology? It's the study of the frequency, distribution, and determinants of health-related states or events in human populations, and the application of the study to the promotion of health and to the prevention and control of health problems. So let's have a look at some of those words. The frequency refers to how common is the disease. So, for example, 20% of South Africans are HIV positive. That kind of information, obviously, one needs to know when planning how many antiretrovirals to buy, what sort of numbers of nurses and clinics does one need to address this epidemic. Then if we look at what is distribution, it refers to how the diseases are distributed in different groups. So for example, are the rates of the disease highest in men, women, young people, people living in certain areas? And again, you need to know that information in terms of your health promotion and health service activities. Determinants, that refers to the causative agents. So we're not going to go into that much today. That'll be in the later series of your epidemiology lectures. And then lastly, all of this information is applied to the study of promoting health and preventing controlling disease in the mass population. So the focus is on the population rather than individuals. And you'll see from the examples how that comes into play. So let's have a little look at the history of epidemiology. These are some of the known pioneers of epidemiology. So Hippocrates is thought of as the father of epidemiology. So at the time, in Greece, people thought about disease really kind of as a supernatural issue. So the gods were angry, you would get a disease. Hippocrates approached disease from a more rational perspective, and he started to look at the relationships between the occurrence of disease and environmental influences. So for example, it might be where somebody lives, what are their surroundings, and how does that influence whether or not they get a disease. And he in fact is the person who coined the terms endemic and epidemic. Then we had Sydenham, who you can see over here. So he was alive in the 1600s, and he was a very interesting man because he was really interested in clinical observation. And so for him, his feeling was that it's more important to observe what happens in a disease and in the population rather than to focus on theory. And that's really the basis of science as we know it. And obviously applied to the study of disease, you'll see later in some of the examples how observation is really critical in informing what is actually the truth of a disease rather than what we think might be causing it. Gallen, he described that lifestyle factors and personality can influence health and disease. And you'll see as you study epidemiology that all of these people really highlighted factors that we still consider in causality today. So environment, lifestyle, personality, and then observation as a way to try and determine how these factors influence disease and health. He also was somebody who wrote quite a lot about the popular belief of the time, which was the miasma theory. Now, this theory was quite interesting. So basically what it referred to was that people started noticing that where there was, for example, sewage with bad smells, the people around that area would start getting sick. And so the belief was that there was something in the air that was actually causing disease. And that was the miasma theory. Grant, who's the gentleman in the middle, he was also a significant contributor to the study of epidemiology because he started to look at mortality data, so in other words, cause of death data, and he was the very first person that we know of to quantify patterns and numbers of birth, death, and disease occurrence. And what's quite amazing about him is he didn't just look at the entire population, he then also broke down the data to see, what were the different causes of death and disease by different sex, so male, female, different age groups, different geographic locations, seasonal variations, and through that study he noted many disparities. And again, this is something that we do in current day epidemiology. William Farr is also regarded as the father of epidemiology, and he, this is actually the wrong information about him. He basically took that mortality data that Gaunt had started, and he continued to do mortality studies, also just aggregating data, and he did it over a much longer period of time. And he is the person, in fact, who originally defined how we define mortality, for example, early mortality, late mortality, which we'll see in a moment. So what happened after the miasma theory was that microbiologists started to be able to examine samples from patients themselves, from water, from soil, and they started to realize when they looked under a microscope that in fact there were a whole lot of microbes that were probably the cause of disease. And so the miasma theory, where the idea was that foul air caused disease, gradually came to be replaced by germ theory. So germ theory states that specific microscopic organisms are the cause of specific diseases. And this theory, as with all new theories, took some time to be accepted, but between 1850 and 1920, it became popularized and accepted in both Europe and North America. So let's just have a look at some of the achievements of the germ theory of disease at around this time. So Lister invented antiseptic surgical techniques. So you can imagine before people had an understanding that germs caused disease, people would go and have operations and there would be no attempt to try and clean the part that was going to be operated beforehand, no attempt to for the surgeons to wash their hands, and so there was quite a lot of mortality associated with surgery that was in fact related to infection, but it was not understood that it was important to have surgical, antiseptic surgical techniques. And so Lister had quite a significant impact on reducing surgical mortality. Another epidemiologist who most of us know about is Louis Pasteur. So what he discovered were two quite important aspects. So the one was he discovered that if you heated, for example, milk or substances that would have bacteria in, that if you heated it, then the risk for disease would disappear. So that's known as pasteurization. And he also developed the first laboratory vaccines. And you can have a look there. I found a very nice newspaper heading where they've summarized some of Pasteur's achievements. And as you can see, the germ theory of disease appears there, and pasteurization. And you can see there the kinds of vaccines he developed: rabies, diphtheria, anthrax. Edward Jenner is also quite a prominent figure in public health, and he managed to prevent smallpox by infecting healthy people with cowpox. So cowpox was similar enough to smallpox that injecting people with cowpox actually conferred immunity in those who were injected with it. Then Semmelweis, he was really important in terms of establishing the connection between hand washing and spreading germs. So this was a time where physicians would go from doing an autopsy, and then they would deliver a baby, then they would go and perhaps do surgery, and so at the time they weren't washing their hands, and you can imagine the spread of germs that happened in hospitals and places where doctors were really encountering a lot of diseases, and specifically microbes, and really just passing from one patient to another. And even to this day, if you look at the WHO health interventions, hand washing is really number one in terms of preventing diarrhea in the communities, but also in hospitals nowadays. Not only do we wash our hands, but we wear gloves, use antiseptic sprays. So this was really quite a critical observation. The other person who one always speaks about when you're looking at the germ theory of disease is Robert Koch. So he really was somebody who developed very superior laboratory techniques, which of course were important in identifying the specific germs that caused anthrax, cholera, and TB. And through his observations and his studies, he developed 4 postulates which really referred to the causality of disease. So he said that the microorganism, which might be a bacteria, virus, parasite, must be found in abundance in all organisms suffering from disease, but should not be found in healthy animals. So a lot of his work was not just on people, but on animals. So he said if there isn't an abundance of this organism in that person, then it's unlikely that they have this disease, and particularly so if that same organism is found in somebody who's not affected by the disease. The second postulate was that the microorganism must be isolated from the diseased organism, and then he would grow it in a pure culture. The organism should cause disease when introduced into a healthy organism. So to prove these different germs cause these problems, he would actually inject that microorganism into a healthy animal and then observe to see for the development of disease. And then lastly, the microorganism must be re-isolated from the inoculated diseased experimental host and identified as being identical to the original specific causative agent. However, as with all theories, they're limited by what we know at the time, and as more knowledge became available, he had to abandon the first postulate, which said that, and we'll go back to that for a minute, which said that the microorganism must be found in abundance in all organisms suffering from the disease. However, cholera was a big disease at the time, and as you probably know, there are a lot of people who are infected with the microorganism but are in fact asymptomatic. So that immediately threw out the first postulate. And of course, nowadays, we know that not all diseases are infectious in nature and are not caused by microorganisms. So some examples would be chronic diseases that we know of, such as heart disease, cancer, schizophrenia. And then I've just put a little picture there referring to atherosclerosis, which we know is connected to deposition of fats in the arteries. So no microorganisms there. And then another person who was very important, and in fact is the person who this institute is named after, was James Lind. And at the time, there were a lot of ships traveling the world on so-called discovery and colonial projects. And what they had a big problem with sailors and scurvy. So scurvy causes a lot of problems with teeth, with skin. And James Lind conducted an experimental study. He worked at the Royal Navy, and then he started through his observations to understand that in fact citrus fruits were really what made the difference between developing scurvy or not. So obviously that relates to vitamin C. And from his studies, new policies were put in place at the British Navy that said it was a requirement to add limes to seamen's diets. Panem was also somebody who contributed to the study of infectious diseases. So he conducted quite extensive observations of measles on the Faroes Island. And what his observations managed to show was that virgin soil epidemics of measles infect nearly all susceptibles. So what does virgin soil mean? It means a place where that disease hasn't been there before. So it's in fact an ideal place to study the development of disease because there won't be any immunity, so it can be very clear what the incubation period is, how easily it is to be infected. So he also noticed that not only did everybody susceptible develop the disease, but also that natural infection confers lifelong immunity. So in other words, once you've been infected, you can't be infected again. He showed that measles struck all age groups. He looked at how many people died and worked out a case fatality rate of 2.8%. We'll speak a little bit more about case fatality and how we worked that out a little bit later. And of course, he was able to determine how long from the period of infection to the period of showing symptomatic disease, which we call the incubation period. Then there's somebody called John Snow, who is probably one of the most famous epidemiologists in public health. And he lived during the 1800s, and again, he's regarded as another father of epidemiology. And he was a very interesting man because what happened was that in the 1800s, there was a massive cholera epidemic. And at the time, there was still the idea of miasma theory. This was 20 years before the microscope had been developed. And he developed this theory that it might be the water that was infecting the people with cholera. So what he did is he developed this map where he found out where every single resident both lived and worked, and then he noted that on the map, as you can see. So it's these little black dots here. And then because he thought there was a connection between water and the development of the disease, he then also mapped the pumps, the water pumps in the area. And if you look at this map, you can see that most of the cases are around pump A. So what he did then was he went to all the people who were infected and he asked them, which pump do you use to get your water supply? And he found out that even people who were living a little bit distant from pump A were in fact using pump A because pump B was felt to be by the people to be contaminated, and pump C, which is down here, was too far for people to walk to. And then what he found from this was that in fact all the people who had been infected were using pump A. And then he himself went personally and shut down pump A, which significantly reduced cholera in this area. And then following the study, he thought, okay, if I've now proved this, let me do a retrospective study. So he went back and looked at some cholera death information or cholera mortality from 1851. And in this study, what he realized is that in this area of London, there were basically two companies providing water to the population. So one was Southwark and Vauxhall, and the other one was Lambeth. Now, the difference between these two water companies is that one collected water downstream of the River Thames in London. What that meant was that it was likely to have been infected by human sewage and some human waste. And whereas the Lambeth company actually obtained their water upstream of the River Thames. So the upstream water obviously hadn't been infected by any kind of human waste. And as you can see, when looking at the numbers that he found, you can see very clearly the highest numbers of death were in the area supplied by Southwark and Vauxhall, and the lowest numbers were those areas that were supplied by Lambeth, which got their water upstream. And then interestingly, if you have a look, some places were supplied by both, and there we can see the figures are somewhere in the middle. And so again, this really is quite remarkable because germ theory wasn't around at the time, and so this was really just based on his idea that there's something in the water that is causing cholera, and added to the conclusions that he'd drawn from the other study. Some other famous studies were by Bradford Hill. So he was an English epidemiologist and statistician, and he in fact pioneered the first randomized clinical trial, and they were able to demonstrate the connection between cigarette smoking and lung cancer. So you'll see later in the epidemiological series of lectures that he developed the Bradford Hill criteria of causality, which are still largely used today, except for one or two of them, and are really quite powerful ways of thinking about and proving that factor A causes outcome B. The Framingham study is another famous study that was conducted in 1948, and that study included more than 5,000 adult subjects, healthy men and women, and then it observed for hypertensive heart disease and atherosclerosis, and even to this day, this study continues. We're now in the third generation of the Framingham study, and it's been a very powerful study that demonstrated the effects of, for example, diet, exercise, taking aspirin on the risks of developing hypertensive heart disease. So what are some of the practical applications of epidemiology? Well, there's 7 uses. So the one refers to health status and health services. And then the other one helps us to determine what are the actual causes of disease so that we know what kinds of interventions might be helpful. So today we're going to be looking at 2 of the practical applications. One is the study of the history of health of populations, and the second one is to diagnose the health of the community. The other applications you will be getting more information about in the further lectures. So let's have a look now at how information on the history of health of populations is helpful. So this slide refers to mortality rates, and you can see that in the 1900s, this is from the United States, in the 1900s, the main causes of mortality were infectious diseases. So we see TB, diarrhea, influenza, and smaller amounts of heart disease, cardiovascular disease, cancers. So the chronic disease is not so prominent, and the infectious disease is very prominent. Jumping to 2009, we can see that in fact there's a complete switch around. And now you have your more chronic diseases, diseases of the heart, cancer, etc., taking prominence. So this is normally related to developments in infrastructure, so improved sewage, hygiene, proper water, sanitation, and then it's also connected to the exposure of the population to different kinds of risk factors. So for example, a sedentary lifestyle, in other words, sitting in a chair all day. It's also related to the exposure to certain toxins, high fats diets, smoking, toxins in food. So this really gives a good understanding of how looking at the history of health in populations is important, because it identifies what are the main risk factors we need to be concentrating on now. And of course it tells you how to plan your health services, because if beforehand you might have had a lot of investments in TB clinics, whereas in this population now you need to be shifting some of that financing towards services that address more the chronic diseases of lifestyle. And then I just wanted to point out that this history of the health of populations can be different in different settings, because as I said, a lot of what are the main conditions relates to the environment, the kinds of lifestyle people are living, as well as the nature of the population. So I included this slide so you could have a look to see how in 2002, in low and middle income countries, you see communicable, maternal, perinatal, and nutritional conditions. So it's mostly infectious conditions and conditions associated with pregnancy and childbirth. And there, that's really what predominates. Whereas if you look in the same year of 2002, in high-income countries, the main causes of disease there are non-communicable diseases. So that would be your heart diseases, diabetes, stroke, mental illness, that kind of thing. Now if you compare that to 2030, you can see in the low-middle-income countries, as their health services start to improve, as infrastructure starts to improve, we see a slight decline in the communicable and maternal perinatal conditions, and you see a rise in injuries, although it's quite slight, but significantly a rise in cardiovascular diseases and other non-communicable diseases. And so again, this information is very important because if you're now planning your health services based on information from high-income countries, you're going to get it completely wrong in a low and middle-income country. And then just to mention that, again, these shifts away from infectious diseases towards more chronic diseases of lifestyle is something that is we're seeing across the world in developing countries. All right, so here we can see this is another graph that is demonstrating the change in certain diseases over time. So diseases of the heart going down in the United States from 1960 to 2013. We see Alzheimer's rising, strokes going down. And so these kinds of, this kind of information, again, is very helpful in terms of knowing what are the main problems in the population. But just to bear in mind that, one needs to think about what are the possible causes of these changes. So it might well be that that disease is reducing. But one needs to think, why is it reducing? So it could be that maybe the demographics of the population is changing. So for example, a population that would be getting younger, in other words, has maybe a high birth rate, and so you have a lot more younger people in the population. That's going to skew the number of people dying of heart disease, because we know that disease is something that only occurs later in life. It also can be that perhaps the diagnostic criteria have changed. So it could be that beforehand a lot more people were being diagnosed with heart disease or stroke, whereas now that the criteria have changed a bit, there's a sudden drop, which actually doesn't mean that there's been a drop in that disease. Another possibility is that perhaps treatment for that disease has improved. So beforehand, maybe a lot of people were dying, but now they're living quite a lot longer. And so that's something, for example, we see in South Africa with HIV and the distribution of antiretrovirals, is that now the number of deaths from HIV have radically reduced, particularly in infants. Okay, and then this slide really refers to how we think about different diseases. So there can be new epidemics. That's probably what we're most familiar with. So one of the most recent ones, for example, would be Ebola. So this is a new disease that comes in and normally affects quite a large number of people and at quite a rapid rate. And they're normally diseases that we don't necessarily have a cure for immediately. Then you have persisting diseases. This category of disease is a disease where we don't really know what the cause of that disease is, and so it's very difficult to treat. We might have some idea of some of the causes, but we don't know enough to really effectively eradicate it. Residual diseases are a little bit different. These are diseases where we know what the causes are, but they're quite difficult to change. So for example, sexual behavior is not something that's easily changed. It doesn't just require a vaccination like something like polio might, for example. And then we have disappearing diseases, and these are diseases that the cause has been identified, we've put into place effective public health programs, and the disease is practically disappeared. Sometimes, there'll be the odd case here or there, but it's no longer at an epidemic proportion. And so examples of that would be smallpox, which has been entirely eradicated, and then diseases like polio and measles, where we still have minor outbreaks, but not at epidemic level. All right, then the second application that we're going to have a look at of epidemiology is how do we use epidemiology to diagnose the health of the community? So this is no longer historical, but in real time. So we need to measure the true dimensions and distribution of ill health in terms of incidence, prevalence, disability, and mortality. So why do we need to know this information? It sets the health problems in perspective. It defines their relative importance, which of course then defines the relative importance of funding for different disease states. It helps us identify groups that might need special attention, so who are the high-risk groups, and we focus our interventions on them. And then of course it helps us to plan health services. So let's have a look at what are some of the common measures of disease frequency. So first of all, you always need to define who is the population at risk, because most diseases don't affect everybody. And so it's very important to know what is the risk group. So the population at risk is that part of the population that is susceptible to that disease. So if we take an example of looking at cancer of the cervix, obviously this doesn't affect men, so you take out half the population. And it predominantly affects women between 25 to 69 years. So that would be your population at risk for cervical cancer. Then prevalence. So prevalence is one of the commonest measures of disease frequency in epidemiology, and this refers to the number of all existing cases of a disease in a defined population at a specified point in time. So how do we calculate this? Well, the numerator is the number of people with the disease at that specific point in time. So normally you would specify. So it might be the number of people with HIV in South Africa in 2015, for example, and then one divides that over the number of people in the population at risk. So sometimes it's defined by the denominator is just the population at risk, and you'll see that sometimes prevalence also uses just the general population. But obviously it makes a lot more sense to have your denominator as the population at risk. So let's have a look at an example. So in South Africa, they did a massive household study by the Health Sciences Research Council, and what they established through that study was that about 19.2% or 7 million adults in South Africa are HIV positive out of an adult population of approximately 36 million. So I've just put the calculation there for you to see. We've got our 7 million people who are positive over the number of adults in South Africa times by 100 gives you 19.2%. And here's a picture really just to illustrate that you have a mass population and then you have a certain number who are HIV positive at any one time. And this study was during 2015, so it's a very defined time period, which is important. So there are a number of factors that can influence either an increase or a decrease in prevalence rates. So some of these would be, sometimes the disease can now occur for a longer period of time. So with HIV, that's definitely the case in South Africa. Beforehand, approximately 15 years ago, they had very limited access to antiretrovirals, and so people would be dying very early. So you can imagine then the number of people at any one time in the population who are positive would be quite a lot smaller than it is now. So even though we have an increased prevalence rate of HIV, in fact, this is a sign that our public health measures are working. Other reasons why you might see an increase in prevalence can be new cases coming in. So there could be mass migration from a country, for example, that has a lot of HIV. Healthy people could be migrating out and so forth. Decreases in prevalence can come from a shorter duration of disease, high case fatality, in-migration of healthy people, or out-migration of people with HIV, for example. So you can go through those by yourselves in detail and just give some thought to how would this affect the prevalence. But they're pretty straightforward. Then we have a look at incidence. So this is different to prevalence. Prevalence is the number of existing cases. Incidence is the number of new cases of a disease arising in a given period in a specified population. So again, the period of time you're looking at is important, as well as how you're defining your population. So if we look at the formula, it's the number of people who get a disease in a specified period divided by the sum of the length of the time during which each person in the population is at risk. So here the incidence of HIV in South Africa, I've simplified it a little bit. So let's just take it in a neighborhood. If there are 450 new cases in the neighborhood of 10,000 people, then our incidence will be 4.5%. And what's important to point out here is that incidence, so let's say all the red people here have HIV. These two might be the only people who developed HIV in 2015. So they'll just be, let's say, these two people, whereas prevalence will include those people who have just become infected, as well as those who were already infected before the year began. So prevalence is always higher than incidence. And so in South Africa, for example, the number of adults with HIV in South Africa is 7 million, but the number of new cases per year is 380,000. Then we have another measure which is called the cumulative incidence rate. So this is the simpler measure of the occurrence of disease, and it refers to the number of people who get a disease during a specified period divided by the number of people who are free of that disease at the beginning of that period. So if you think about it, really what it relates to is how likely is it for somebody who doesn't have the disease to get the disease during that time period. And then just to mention, of course, there's an interrelationship between these different measures. So prevalence rate is dependent on both the incidence rate, because obviously the greater the number of new cases, the higher your prevalence is going to be. And it's also affected, as I said earlier, by disease duration. And the cumulative incidence rate of a disease depends on both the incidence rate and the length of the period of interest. And prevalence will obviously equal incidence times the duration of the disease. All right, then let's have a look at some other measures of disease frequency. One of the commonest ones, which we could see even those early epidemiologists were using, was what is the case fatality rates? In other words, of all the people infected with a disease, how many of them will actually die? And this is important to predict the outcome of diseases, to tell people, this is your chance of surviving this disease. And again, it's important to plan your health services. So the formula is pretty straightforward. number of deaths from the disease over number of diagnosed cases. So I've included here just an example from Ebola. And this example is quite interesting, and this is often the case with diseases. If you look at the bottom of the graph, you can see it's been disaggregated by age. So here, if you're under 15, your chances of dying from being infected with Ebola are roughly 65%. If you're a bit older, your chances are maybe 55%, and if you're older than 45, they're jumping up to around 70%. And so this is often the case that we see with different diseases, that they affect different age groups differently, normally based on immunity, but there can be other factors as well. And again, this is important to know in terms of, what kinds of interventions do you need to do for which age groups, and when do you need to hospitalize people. Okay, then mortality rates, again, is obviously a very critical epidemiological measure. So it really just measures the number of deaths in a population scaled to the size of that population per unit time. So that sounds like a little bit of a mouthful, but don't worry, we're going to break it down. Typically, it's expressed in the units of deaths per 1,000 individuals, and that's really just because populations are really huge. So we don't want to line up with really large numbers that are hard for us to understand. So normally, it's just divided by 1,000 so that it's per 1,000 people. We have early mortality rates, so that's the total number of deaths in the early stages of an ongoing treatment or immediately following treatment, and then the late mortality rate would be at a later stage of treatment. And so oftentimes the why we make that distinction is that the early mortality rate often speaks to how effective is our treatment, whereas the late mortality rate often speaks to what is the likelihood of complications. All right, then there's a whole number of different mortality rates. I won't go through each one in turn. You can have a look at them. But I just wanted to pull out maybe just to make a few comments. So some of the most important mortality rates are maternal and perinatal mortality rate. Why are they important? Well, as I showed you that slide from low and middle income countries, we still have significant problems with deaths during pregnancy, childbirth, and immediately following birth. So those rates are quite important and are in fact monitored in the Sustainable Development Goals at a global level, as is infant mortality rate, because again, a major cause of death, particularly in low and middle income countries. And then we have, looking at the whole population, standardized mortality rates. So what is that? This represents a proportional comparison to the numbers of deaths that would have been expected if the population had been of a standard composition in terms of age, gender, etc. So let's just go into that a little bit because it can be a little bit confusing. So what we know is that the number of deaths per 100,000 are influenced by the age distribution of the population. Remember I spoke earlier, obviously if your population is a lot older, you're going to have much higher mortality rates, and also depending on what diseases are in that population, they can affect different ages differently. So your age structure of a population will make a big influence on your mortality rates. So two populations with the same age-specific mortality rates for cause of death will have different overall death rates if the age distributions of their populations are different. So let's just have a look at some of the age distributions in different populations. So we have certain countries, often low and middle income countries, where we have a demographic pyramid where you can see most of the people in this population are quite young. And as you go up to all the ages, there's not really that many people there. Then you have other countries where there's slow population growth, where most of the age groups are fairly well represented, and then it's just a few people right at the top. So you can see very, very different population structures. And then in Germany, they have negative growth, where in fact the base of the pyramid is actually narrower than the middle of the pyramid. And so you can imagine now with a disease such as HIV, for example. HIV, we know, affects this kind of population and a lot of infants as well. So in populations where that proportion of the population is smaller, you're going to have very different death rates per disease, just simply because of the different age distributions. And this is why the World Health Organization applies a standardized age structure that you apply to every population to allow for meaningful comparison. And then this you can have a look at in your own time. It's really just gives you an idea of how there are very different causes of death in different age groups. This particular one's in the United States, but one can get these kinds of graphs for any country really. And you can see, obviously, as people get older, the kinds of things they die from is quite different. So let's finish off by having a look at some of the major achievements in epidemiology. So one of the most famous achievements of public health is the complete eradication of smallpox. So if you know anything about the history of medicine, smallpox was an illness that really caused quite a lot of death and morbidity around the world. And once the vaccine was developed, the World Health Organization went on a major vaccine program around the world, and smallpox has now been eradicated. So the last case that occurred was in 1977. So that's really one of the most famous achievements of public health. Another example was from Japan. So here, what they were finding is that there was mercury poisoning in some of the residents of Minamata Bay. So how epidemiology helps is that they had to look at all the different people who were affected by mercury poisoning. And then they started to discover that actually most of the people who were affected were fishermen. And then analyzing the fish, they discovered that in fact the methyl mercury was coming to the people through the fish. And so this was one of the first reported epidemics that was in fact caused by environmental pollution. Nowadays, of course, we know a lot of examples of this, but this is again a way in which epidemiology really was helpful in identifying the cause by observation, questioning, and then was able to prevent that poisoning by reducing people's consumption of that fish. Rheumatic fever and rheumatic heart disease, this is, has been a big problem in particularly low and middle income countries where we find that poverty, crowded areas predispose people to developing post-streptococcal upper respiratory tract infection, and that this can then cause rheumatic fever and rheumatic heart disease. So having discovered this connection between post-streptococcal respiratory infection and rheumatic heart disease, now what happens is that people will then be given penicillin as a prophylaxis, because penicillin removes the streptococcal infection and so prevents advancement of that disease, which previously people would die within a couple of years. And now people just go on the penicillin prophylaxis and they can live slightly shortened lives, but far better than how it was before. And this study is also important because it was one of those studies that highlighted the role of both social and economic factors. And you'll see when we go into the study, into your further lectures on causality, that oftentimes for something to cause a disease, it requires the presence of a number of factors. And very often, particularly with infectious diseases, social and economic factors are major contributors to the development of disease. Another major achievement was linking lung cancer to smoking. So in the days before smoking was common, lung cancer used to be very rare. But then in the 1930s, of course, there was quite significant advertising of smoking. Doctors, in fact, advertising cigarettes, saying it's good for your health. And what we saw was a dramatic rise in cigarette smoking and a dramatic increase in the occurrence of lung cancer, especially in industrialized countries where more people smoked, but they were also working in factories where they were exposed to other risk factors. So the first studies that managed to link lung cancer and smoking were published in 1950. And of course, as you know, the main cause is tobacco smoking. And this was very important because, until they could change, try and change policy around tobacco advertising, tobacco pricing, you first need to prove that in fact this is the cause of that disease. Otherwise, it's very difficult to convince policymakers to change policy. And then again, just to mention, in terms of cumulative causality, there are, of course, other factors that can increase your risk for lung cancer. So, for example, if you're a smoker and you work in a place where you're exposed to asbestos, your chances of getting lung cancer are even higher than somebody who just smokes. Urban air pollution also a contributor. Okay, then one of the other major achievements in public health is around HIV/AIDS. So it was first identified as a distinct disease entity in 1981. So that took some time because a lot of people started presenting with symptoms that didn't really fit any known disease. And through epidemiological observation, the syndrome of HIV was then defined. And as you know now, we have many people living in the world with HIV. And I think, at the time, again, when HIV first came out, for me personally, I can remember working in hospitals, and, if somebody had a diagnosis of HIV, particularly with children, they would die very quickly. With adults, they would also have very shortened lives. But with the advance of studies around antiretrovirals and defining also who are the high-risk groups, who's dying, we now have antiretrovirals where a large part of the population is on antiretrovirals, and now people can actually live the same length of a life that somebody without HIV can live with, which is pretty remarkable. Of course, there's a huge number of the population who's still not on antiretrovirals, but everything comes in time, and the logistics around rolling out those programs addressing stigma then come into play. So I just wanted to give you some other resources if you're wanting to read a little bit more about the different measures of mortality and see some more examples. You can click on those links. It's quite important to really go through examples, and there wasn't enough time in this lecture to go through too many examples, but I would encourage you to have a look there, do your own calculations, and yeah, let me know if you have any questions. So thank you very much for attending the lecture, and I hope you enjoy the rest of the lectures on epidemiology. Thank you.